Can you tell me what makes a good gynecologic surgeon?
All right, so I still pretty much think about things in an old style way. I I I think a lot about the technicalities of surgery, and so when I give a lecture about how to be a great surgeon, I I say that the surgeon has to really know the subject. That's obvious, but they have to know the anatomy. And you'd be surprised worldwide, people don't really know the anatomy as well as you think they should know to be able to do surgery. So you need to know the subject and the anatomy. You need to know how to do the operation, and that should be taught to you by somebody. And then that would be the baseline of what you should be able to do as a surgeon. But as you get more advanced, you start to anticipate and solve problems. And I think that's one of the landmarks or one of the things that make an average surgeon into a better surgeon is anticipating, preventing, but then also solving problems or avoiding complications. And when I say solving problems, that's one of the themes of surgery for me is that you get presented with a difficult situation that you didn't anticipate in their pelvis, and you have to have the knowledge and skill and mental aptitude and emotions to solve that problem. And then if you can solve it, then usually you can keep your complication rates pretty low. And that is one of the things that really defines a great surgeon. Um, and then I think a really top-notch surgeon should be at least aware of their results. Um, I initially thought they should track their results, but maybe that's not fair for doctors in private practice. But you should be seeing your patients back and seeing how well you're doing, so that you can then learn um, from your good outcomes, but also learn from your poorer outcomes and your complications. And that's how you get better over time. I think, and become make go from an average surgeon to a more advanced surgeon.
It's funny that somebody who said something very similar to that is Joe Schaefer. He was saying how we now have a generation of surgeons that don't see their own post-op patients. And I was telling him how you saw all your own post-op patients and you also did annuals on a lot of your patients, and really had longitudinal care, which is a practice that has fallen by the wayside. We have nurses who now see the post-ops, and there's sort of no longitudinal follow-up, so people aren't learning about their own surgeries, right? Um, Especially when it comes to native tissue outcomes, people are just relying on data rather than their own experiences, understanding that, you know, right, for we've always talked about this, the anterior wall may recur, but the patient may be fine, so why would you count them as a failure, right? So
Right. Well, when you're talking about vaginal reconstructive surgery, you just need to look at the vagina after you've done the surgery to understand it. You might get good pop cues, but it might not be really great when you actually put your hands on it and feel the tissues and stuff. And so in the old model, I pretty much always saw my post ops up to a point. After they were voiding, and I did my own post op visits because that's what we were taught to do, um, and we thought that was important. And I think that when you see something that didn't go well, like say a hematoma in the rectovaginal space, if you're not seeing it with your own eyes, you maybe won't think about it as much when you're trying to prevent the next one.
yeah.
I just had a hearing surgery, a cochlear implant, and um, I saw the surgeon twice, once pre-op and when he did the operation. And then an audiologist took care of me afterwards. At the 4 month visit, I actually asked the audiologist, who was super good, how does the surgeon know how well he's doing? Because he never saw me again. Just exactly what you're talking about.
Right.
And she goes, well, he knows because we're in committees and we know our general results and we're tracking our results. But I know he doesn't really know how I'm doing. He knows in general how various situations are working. Um, and I think you can evolve well that way. So I really think that younger surgeons should at least see their post-ops once. It's not that hard to do. Even if you're doing 8 surgeries a week, you spread those post-ops out, and it's kind of fun to see them, but you learn from that. And then you know all the little problems, vaginal pain or urgency or avoiding dysfunction or other sorts of things, vaginas that aren't healing as well as you think, granulation tissue, all those little problems go in your memory and you want to avoid them over time. And that's your evolution over a 10 and 20 and 30-year period.
I'm so happy you said that. I feel in this new job that I have now. So in my old job, I actually fell into that sort of wheel, like the wheel of like just doing as much volume as possible. So I put my post-ops onto somebody else, somebody I trusted. But now in my new role, I actually am using this as a way to revisit looking at my outcomes. So now I'm seeing all my own post-ops again, and I'm sort of relearning some of the things that I think I should have been looking at a few years ago. And it's been really fun. And you actually forget how fun it is to see your patients when they come back, especially those with gratitude, right? It's validating. We work so hard. So it's really nice to have a patient actually just say, thank you, I feel better, right? So
Oh, right. It's fun because most of what we do works pretty well.
right.
And so they mostly tell you, thank you, you did a nice job or
Right.
whatever. And I'm having sex again and I'm happy with that. And, I'm not having pain or whatever. And then the 1 out of 10 that's really unhappy, you learn from me.
Right.
And it's fair that you should take some of the heat for that rather than some nurse practitioner
Correct.
um, having to listen to those complaints.
Correct. So I'm glad you answered that question that way. Um, who have been or who were your mentors and sponsors in your career?
Well, in thinking about that, they're mostly early people. Um, I graduated med school in 1980, residency in 1984. So the first guy who influenced me a lot was named Fred Zussman. And Fred Zussman was a really famous obstetrician, chairman at Ohio State um, for a long, long time, and did a lot of research on preeclampsia. And in the 80s was really quite famous. And he just from one meeting interviewed me and then was my sponsor and got me into Tufts University to do residency. He didn't have to do that, but I told him I wanted to do OBGYN and I wanted to do gynecologic surgery. So he said, well, this guy at Tufts, the chairman, is named George Mitchell, and he's a famous guy, and he'll be your mentor. And so they ranked me high at Tufts, even though they didn't really know me, based on what Fred Zussman said. In the old school, these guys would go out to dinner at APCO, CREOG meetings and stuff, And so Fred Zussman did that for me. And then when I went to Tufts, his friend was George Mitchell, who was trained in the 30s as a general surgeon. He was an early SGS member and very well known in the 70s and 80s. He was chairman at Tufts for 25 years or so, and then retired there and went and worked 10 more years in San Antonio under Carl Powerstein. And George Mitchell was a gynecologic surgeon, a urogynecologist, a GYN oncologist, board certified, and a breast cancer specialist, all because he had started out as a general surgeon. And he was chairman of OBGYN, but really only did gynecology. And he was unusually nice to me, even as a resident, when he wasn't always nice to everybody. But I took an interest in what he was doing, not in oncology, but in benign vaginal surgery. So then when he went to San Antonio, I followed him to San Antonio to be what was essentially like a fellowship. But at that time, there were no fellowships. So uh, you went and became a junior attending for low pay. And then they only gave you like one clinic a week. And you then could just operate with the master surgeons and do your own cases, and they would help you. And that's what happened. And I was with him for 6 years, and he was really the one that guided me onto how to become a academic surgeon, academic pelvic surgeon, and how to also uh, um, behave with residents and behave in teaching conferences, and how to do things correctly, like a gentleman, the old style guys, where they were polite in conference but strict. And he was good at all that stuff. Then probably the third guy was named Carl Powerstein. He was the chairman with Mitchell. And what he's all these gentlemen are dead. Um, but Carl Powerstein was a better academic, and he taught me how to the importance of research, and he had some grants and stuff like this. He was out of Johns Hopkins, and really it mentored me that way until I left San Antonio. Then when I went to Cleveland, I went to University Hospital for 3 years, and by then I was 6 years out, but I was mature enough to go ahead and start these sections that most people, most departments needed somebody to do this, and to do vaginal surgery and urogyn and urodynamics. And the chairmen at that point were mostly facilitators. They paid you, they gave you support, they gave you operating room time, but they didn't really mentor me anymore. And at that time, I'm contemporary with John Delancey and Peter Sand and Linda Cardozo, uh, Nicolette Horbach, and Peggy Norton was a little bit younger, but those are the people that were going around to different departments and starting their urogyn programs.
Some of these individuals have been part of this interview compilation also. So it's nice to hear their names as the people you remember as sort of peer sponsors and peer mentors, and also senior mentors.
Well, many of them are so far gone, most people won't remember them anymore.
Yeah.
And even Ray Lee, who was sort of somebody I looked up to, has been gone for quite a long time now, and so most people never met Ray Lee.
Yeah.
And so I was, happy to be able to do that. But that's what happens. Moves on.
Well, speaking of, then I'm going to jump ahead. At some point, that's going to happen to you, and there's already a lectureship in your name. How do you hope to be remembered in our field?
Well, how I'm remembered in SGS is sort of set up in the legacy of that lecture, and I'm very grateful for Amy Park and the other people that thought about that and fundraised for it. So it's a sort of um, amazing to me and sort of humbling that I would have that lecture. I hope that the lectures, continue and are about surgery education and things like that. But I assume that that's the main way I'll be remembered. I still plan on going to SGS meetings. I don't go to any other meetings mostly anymore. But I'm happy with the SGS meeting. I think it's improved a lot. I'm a past president too, so it's really the past presidents I think should go to the various dinners and things that they ask you to do, and it's good for the society. When I was younger, I liked to see the old past presidents walking around, even if they weren't operating anymore. You could still talk to them and maybe learn something from them, or it was just kind of fun to be around them. And so I'm willing and happy to do that kind of thing now.
Going back to being remembered, you've trained a lot of us. How do you hope we remember you?
Well, you remember me. I, I, I think I had about 30 fellows, and it's probably that's in a way that's is really kind of my legacy, and that the way I look at it is the best contribution I made to uh, this whole subject of surgery and medicine is the um, teaching of the advanced practitioners in our specialty who could then go on and teach and be leaders. And so I think that is the contribution that I'm most proud of. All right. I'm proud of doing a lot of operations, and I'm proud of some of the research I did, but that wasn't really unusual. A lot of people have done a lot of good research, but not a lot of people have trained as many young, smart surgeons as I have that went on to leadership positions and or positions of authority and are teaching people. And so I'm proud of that, and I get along with almost everybody, and I'm really happy to see them at the meetings and stuff. So I'll be known for operating with those guys, and they a lot of times remember operating with me. Remember, I don't like to say this at home very much, but I spent more time with fellows when I was working than I did with my kids sometimes, and because you could spend sometimes literally 8 hours face to face 3 or 4 days a week, and that's a lot of time, one-on-one time you have with people. And so I'm really happy with being able to do that.
Uh, Again, I mean, that's the best answer ever. I once told somebody, so just so I'm like tearful, like hearing you and talking about this, but I, I've mentioned your name a lot during these interviews, but also when I talk about you, I say, Mark and I have a special relationship. He was my mentor. He taught me everything that I know about vaginal surgery. He gave me a lot of hard life lessons too, but he's like I have a couple dads. He's like an additional dad to me. And then I once said to somebody, I think I spent more time with Mark in those 3 years than I did with my own dad. And so I said that too. And so that's perfect. Um, do you have a specific SGS memory, one that you can actually talk about? Because a lot of SGS memories happen after hours because the meeting's really fun. But do you have any specific memory that you want to share?
Right. I actually do. I wonder if Mickey Karam picked the same memory. But what was used to be the most fun thing about SGS, okay, was in the earlier days, like we're talking about, like say early late 80s. Um, in the late 80s, and say 88, 89, 90, 91, 92, we were going to New Orleans to the Fairmont Hotel. And it was the same hotel, same meeting every year. And they had a bunch of all the top vaginal surgeons in the world, in the country, and a few from Great Britain went to that meeting routinely. Not a lot of residents, but it was all these older men and women, a lot of men, but some women that from Mayo Clinic and Cleveland Clinic and Duke and stuff, that in the southeast countries where they southeast states where they really liked to do vaginal surgery, and Bob Schul and those kind of guys, and they would all go there and talk about surgery. That was the whole meeting. But then afterwards, they would go to New Orleans. We were in New Orleans. They would walk from the Fairmount about 3 blocks, 4 blocks into, the the uh, the neighborhoods where all the restaurants were, right? The French Quarter, whatever. And these guys like to have fun, so they would go to restaurants and maybe have a drink or something, and then have a really good meal and talk surgery for another 4 hours because they were so into it. And I have one particular time when Mickey Karam and I were walking around, and I think Mickey was only about a year out of his fellowship, and we were in suits, and we kept seeing these guys walking around, laughing, talking about surgery, and we just wanted to get up close to them and hear what they were saying. And that walking around that night and having dinner in restaurants that they were all, and seeing them interacting that way was what I remember the most about SGS.
I love that. I don't think he gave me a specific memory. I think he sort of was a little bit more vague, but that's
he remembers this because
yeah,
last time I was with him, he asked me if I remembered this
yeah.
one night in New Orleans walking around, and some guy, he had his suit on. He always got dressed up, and he had really nice shoes, and he was eating a hot dog from the street vendor, and some guy came up to him and asked to shine his shoes. So the 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 kid, Mickey, said sure. So the guy like buffed him for like a minute, and then he said that'll be $20, and Mickey gave him $20, and he walked away. He didn't even hardly shine him. He just like got the dust off him. And I said, Mickey, that was the stupidest waste of $20 I've ever seen. And we just laughed about it, And that was that same sort of night, walking around down there.
That's a good memory. My last question for you is, I bet you I can guess, I think, but I'm going to wait to hear what you say. What's your favorite, or has been your favorite, gynecologic instrument, the most indispensable instrument, and why?
I think I know what the answer is. I don't think you would be able to pick what I say. But when I think there's classic instruments, right? Like Kelly clamps and stuff like this that came right out of Kelly's textbooks in 1900. Okay. And then there's innovative instruments. And like a cystoscope was innovative, a laparoscope was innovative, trocars were innovative. Bulking is innovative, and TVT is innovative. Well, I think there was a problem that we had a lot of trouble with in the 80s and 90s, and that was how to get a stitch into the sacrospinous ligament. And because we were using a Deschamps ligature carrier, and that's what Dave Nichols used and taught. But you had to do it in a certain motion with your right hand, and you had to go from bottom to top. But if you didn't roll your wrist correctly, you could go behind the ligament and get bleeding. And that was an ongoing problem that no one could really figure out how to get the stitch in. So when the Capio came out, I thought there were about 3 or 4 other devices to put a suture on the sacrospinous ligament, but they didn't work that well. And so Capio really solved that problem. And you could engage it, pull it out, and not only did it get it top to bottom with little risk of bleeding, but you didn't need to capture the stitch with a second instrument. It pulled the stitch out for you and created that loop. So I think because it was innovative and solved a difficult problem that I was having to deal with for decades, I think the Capio is my favorite instrument, and I admire the guys that created that. What did you think I would say?
I thought you were going to say the Breisky retractor.
The Breisky retractor. Well, the Breisky's, Dave Nichols was a huge Breisky retractor.
I know. I remember you telling me that.
And so I didn't think of that, but that was a really good retractor. And he thought if you had that, you could then see the ligament and be able to stitch it properly. So it's all part of that operation, which is a hard operation to do well. It's a hard operation to teach on the table, and it's a hard operation to teach in a lecture room. So, but yet worldwide, it's one of the most useful and curative apical prolapse procedures. And it's also a good anchoring point for small bits of mesh that are popular in South America. And so it's important that you are able to negotiate around the sacrospinous ligament.
Yeah. Well, what I love about sort of the sacrospinous suspension procedure is, it was thought of for a long time as a post-hysterectomy, mainstay surgery. But over the years, certainly in North America, but we know that this had been going on in South America for a very long time. It's also a mainstay surgery for primary, uterine prolapse procedure, surgery also. So it's a beautiful surgery. But yeah, I thought you were going to say the brace key. The brace key is Mickey's favorite instrument, but interestingly, John Delancey's favorite instrument is the Deschamps.
That's
And
right.
so,
Yes.
but we'll make sure that this interview doesn't get in the hands of Boston Scientific, because they probably would use your clip over and over and over again.
But I'll tell you what, most fellows right now have not seen some of the more severe surgical complications, like fourth degree lacerations in
Yeah,
obstetrics. They don't see that hardly in a whole residency. Most of them have not seen a big presacral, I mean, not presacral, but like maybe a gluteal
yeah,
vein or artery bleed behind the sacrospinous ligament. They haven't seen a pudendal artery bleed, which is horrific. Um, and I mean, in the early times, your teacher wasn't even more experienced than you sometimes on some of these operations. We were kind of learning them as we go. So I got in the rectum during sacrospinous ligament. I got pudendal nerve. I got bleeding behind the sacrospinous ligament. And you don't get to see it too many times. You don't have to see it too many times before you learn not to do that.
right,
And I'm not saying that people should see complications, but uh, once you've seen them, it makes you better. And so every complication that a surgeon runs across, surgically, I'm talking about, she should learn from that experience. Even though it's a difficult experience emotionally and technically, she should learn from it. And that by learning from that experience and how to do it, you can then say to yourself, how can I avoid it the next time? And that's what we're coming back to that first question. That's the first step toward making you an expert surgeon.
and don't you think that's also part of, if you're going to be an innovative surgeon, right? If you're going to be a change agent, that you have to be also willing to, if you're going to be one of the firsts to have those complications and learn from them, and you have to know how to build resilience and have that willingness to be that person.
Right. Well, if you're doing really innovative stuff, there's innovative and there's innovative. And there were some surgeons at the Cleveland Clinic in urology and colorectal surgery that were so innovative that they got just too many complications, and they
Yeah,
weren't something that every department wants to have to deal with. But they really learned how to do things by doing that. But the patient may suffer a little bit, so you have to you want to innovate but keep things safe. And you know, Cecile, as well as I do, that as you learn new operations, they don't always go perfectly, but you definitely get better at them, and that's then your patients all benefit from
yep.
that.